I would like to introduce Dr. Taylor. She is a board-certified adult nurse practitioner and a doctor of nursing practice. She is passionate about the role of the nurse practitioner as the primary caregiver, blending the researcher, educator, advocate, and clinician roles in a holistic model, REACH, of care. Her motto in practice and in teaching is, "Students do not interrupt my work, they are my work." She has 35 plus years experience as a RN and 22 years as a nurse practitioner. She has vast experience in academics, teaching clinical courses in the emergency department, and lecture courses which include critical thinking. She joined the South University nursing faculty in August of 2013 as an adjunct and accepted the position as Assistant Program Director of the DNP in May 2015. She continues to precept FNP and DNP students several graduate programs in Virginia and at her faculty practice site in College Health. Dr. Taylor is here today to talk with us about the day in the life of a DNP, Reach the Essentials. Thank you very much for joining us this evening, Dr. Taylor, and I will now turn the controls over to you.
Hi, Kim. Can you hear me okay?
I can.
Great. Well, thank you for that invitation to participate in the QEP and that warm introduction. And yes, students do not interrupt my work. They are my work. I'm in academics, both in faculty practice as well as teaching for South, and have enjoyed that for a good while. I want to welcome all the students, faculty, and staff, and if there's any guests in the house tonight to participate in this. We hope to make it interactive. I want to give a special shout out online to the director of the DNP program online, Dr. Lee Horton, who I know is on listening tonight, as well as Dr. Sarah Torres, who is the Associate Dean of our online program and the chair of our graduate program online. And both of these leaders in nursing have mentored me and have encouraged me to participate in the QEP, so I want to thank them. As Kim mentioned, I have been a nurse for a good long time and as a DNP for about 6 years. So a little new to that, but so is DNP. And this presentation is to sort of bring us all on the same page. But this is not about me. Let me make that very clear. This is really about you, students. And this is about your future in nursing and the impact that you can have on patient outcomes. And I'm glad that you've joined us. And I hope that you are going to be curious, open-minded, and like discovery about new things about yourself as well as about the profession that you have chosen. This is Making It Real. That is the last time you'll see a picture of me, but since we're talking about being real and from the classroom to the career, that's me. I have to warn you that there is some kinesthetic slides in here, so if you should get dizzy, just close your eyes and listen. Our journey begins with climbing, discovering, and telling a story. Everyone has a story. All stories start within the beginning and, of course, have an ending, which is very important. However, it's what's in the middle. What is the journey that shapes and molds us? I will be sharing pieces of my story, and you will also hear pieces of other people's stories and see pieces of other people's stories. And I hope the message will be the same, to continue your nursing journey. You know, I pondered for a long time about the essentials, not only as a DNP graduate and now a DNP faculty, but also as a practicing DNP. And what I wanted to share with you today was a model that I've developed related to the essentials that uses the acronym REACH, Research, Educate, Advocate, Clinical Expert in a Holistic Model of Care. This is one way that I have wrapped my head around the essentials, and I hope that you will see the relevancy in it. So what are we going to hope to accomplish tonight? What's in it for you? What do you want to get out of this? What's your takeaway? Well, I hope you take away with how the DNP came about and what it is and what the essentials are and how this practice model may connect with the essentials, maybe make it more simpler to understand. But objectives 4 and 5 are I'm most interested in for you is that I hope you apply this knowledge to discover your passion in nursing, and I hope that you're inspired to continue your journey in nursing. You know, nurses are lifetime learners. We are a diverse profession because we have the opportunity to practice in so many different ways. Our practices could be L&D, emergency medicine, public health, primary care, school nursing, industry nursing, correctional nursing, educators, researchers, advocates, lobbyists. It goes on and on. I am convinced that nursing is the most diverse discipline on this planet. But what I see happening in nursing is that sometimes people lose their vision and they get disillusioned or disenfranchised. And so they might drop out of the workforce. And I'm challenging you tonight, no matter what level you're in, to stay in the workforce, to stay apprised, to stay educated, to stay informed, and to stay in it to win it. And we know where that comes from. And so we hope that this will help you become more inspired and motivated. So simply put, our outcomes are using the who, what, when, why, where, and how of the DNP. You know, we are the newest nurse degree, so we're the new kid on the block. So we have some things that we've learned from our newness, and we have some things that we will be projecting for the future. And so we're going to break each of these down. And so I hope you're curious about these. But I'm also curious about you. I want to know, and Kim did a nice job asking where you are demographically located. I want to know demographically who you are. So we're going to have a poll, and I would like for you to take just a few seconds and identify with the, select the one that most represents who you are. And Kim will help us with that.
Okay, I just launched the poll, and we have attendees responding.
Great.
So far, we're up to 80%, 85% voted. Okay, I'm going to go ahead and close the poll, and we have 71% MSN to NP, 18% DNP, and 12% other. So I'll close that and share those results. So again, it's 71% MSN NP student, 18% DNP student, and 12% other.
Wow, that is quite impressive. I will tell you, when Kim asked me to participate in this, I said to her, well, who will be my audience? And she said, oh, most will be RN to BSN students or early nursing students. So now I'm very nervous, Kim, because these are not only students that I've probably taught, but these are colleagues as well. But I am glad that you're here, and I'm glad to get that feedback. So thank you for that. The next question is a little test of do you know, and I anticipate that all of you, knowing your demographics now, know this, but if you'll launch the next poll, and I'd like to know if the answer is Doctor of Nursing Practitioner, Doctor of Nursing Practice, Doctor of Nursing Professional. What does the DNP acronym stand for?
Okay, let me go ahead and launch that one. And voting has begun. We're up to 80% voted, 85. We'll go ahead and close that poll, and we have 94% Doctor of Nursing Practice and 6% Doctor of Nurse Practitioner.
Okay. Well, the majority of you got that correct, but the reason I threw this in there is because this is very much a part of the catalyst for talking about what and who are DNPs and what they do. So a DNP may be a nurse practitioner, but the correct title is Doctor of Nursing Practice, who may be other than a nurse practitioner, and you might also refer to them as Doctorate of Nursing Practice. So in this case, B is the correct answer. So who are our DNPs? And who are our Doctors of Nursing Practice? Unfortunately, there are many health professionals, physicians and other disciplines, and even nurses that do not understand the Doctor of Nursing Practice. And so if they don't understand, how can our patients understand? I make a point to tell all of my patients that I am Dr. Taylor, and then I pause and say I'm a Doctor of Nursing Practice and an adult nurse practitioner. And that is not to apologize to them that I am not a medical doctor. That is not what I'm doing at all. I am tooting my horn that I have a doctorate in clinical practice. But we should be very careful as DNPs and in any level of nursing to distinguish our credentials among our patients. And it's part of educating them. There's an old cliche that is all physicians are doctors, but not all doctors are physicians. We have doctors of pharmacy, therapy, doctors of chiropractic, and yes, we have doctors of nursing. And remember the controversy in The View, The View, the ABC talk show with the doctor's stethoscope? There's no such thing as a doctor's stethoscope. It's just a stethoscope. And many disciplines use this tool to practice. So I want to draw your attention right now to this short video clip. Let's keep our fingers crossed that this works. And I apologize in advance if any of you have difficulty hearing. Kim and I have been working on the technology, but hopefully you'll be able to view this later if you can't. But this is a little sort of a combination of whet your appetite about DNPs and sort of get your heart pumping. Well, a little aerobics here. Uh-oh. Okay, so didn't you want to just get up and put your tennis shoes on and run right through that? I mean, that was the most exhilarating because it brought together so much about what DNPs.
I'm so pleased to introduce
sorry.
to you, Dr. Nancy Rutgers.
Hold on.
As you all know, Florida, as we've been publicizing it, has some of the most outdated.
Sorry about that. So again, we want to kind of run and enjoy some of the things that they talked about, but there was two take-homes from that clip that I really want you to think about. One is the message, it will improve the image of nursing, and we need to do that. The second message that I claim from that is that we need to double the nursing doctorates by 2020. Now we know that there are about 8,000 DNPs right now in the United States. We need, in less than 4 years, about 16,000, and I would say that number is too low. So who are DNPs? We've already established that they're nurse practitioners, but they're also nurse midwives, nurse anesthetists, clinical nurse specialists, clinical nurse leaders, nurse executives, nurses administrators. They have specialties in informatics and other things. But there's one group missing from this, and I only bring that to your attention because we need to stay tuned about what's going to be evolving and happening more in DNP education. So the group that's missing is nurse educators. Now, it is true that nurse educators can be any of those that are listed there, and that nurse educators may have doctorates other than a practice doctorate. They may have a PhD, and they bring wealth of research and understanding to students. They also may be an EDD. But the point here is that with this evolution of the Doctor of Nursing practice, there's a lot of chatter about nurse educators being strong clinicians that are teaching our students, and that we need to recognize them in this arena as well. So the word on the street, actually the word from the American Association of Colleges of Nurses, and Dr. Karen Kester and I spent some time together talking back in July, is that nurse educators are actually being considered, and when the essentials are going to be rewritten or revised in the next 2 years, it's likely that nurse education will be a part of that. So we want to not exclude them, but show that they are a very important part of DNPs, and many of us are educators. So what do DNPs do? Well, we are definitely changing the face of healthcare. We are disrupting some broken pieces, and we're piecing things back together. We do this through problem solving and through leading in innovation and in healthcare policy, and overall we're impacting patient outcomes. Now, this does not come without controversy. We are very controversial. There have been states that said that they don't recognize us, and there's been possible suits. They were all shot down from states that said, no, you can't be called a doctor, or there is no degree as doctor of nursing practice. All of that has now been laid to rest. And so we're moving forward, and we're pressing on. And we do this through the nursing process. We go back and assess and develop and implement and evaluate, and then we start the whole process over again as we problem solve. We are a practice-focused profession, and we're touching every inch of nursing from the bedside to the boardroom. And I don't have a crystal ball in front of me, but I clearly believe that in my lifetime, DNPs will be giving bedside care in hospitals situations. not only directing care, leading care, managing care, but giving great care to patients at that level. And certainly we're doing that in the primary care offices. Gone are the days that nurses have no voice or a limited voice. As nurses are leaders, they're heads of hospitals, primary care diagnosticians, manage patients' anesthesia, deliver babies, create new programs, educate patients, lobby on Capitol Hill, and that's just to mention a few things. DNPs are disrupting the healthcare as we have known it. They're calling things out, they're narrowing gaps, they're impacting health literacy, and they're doing this through teaching, collaboration, research, and many more attributes. So when do DNPs evolve? The doctor of nursing practice, as I call it, the new kid on the block, is deep-rooted in our past and securely tethered to our future. When I graduated in the early 1990s with my master's in nursing and was being prepared to set for the nurse practitioner exam, I was encouraged by the faculty to continue in the PhD track. Although I was deeply flattered by their encouragement, I needed a break from school and I wanted to use my new skills as a nurse practitioner in my community. But while in the graduate program, we heard this buzz about a non-research doctorate, and that's what they called this when they first started talking about it, a non-research doctorate. So those of us that were in clinical tracks, we were very interested in finding out more. It was intriguing. So more than 15, 20 years ago, this concept was being talked about around dinner tables, formal and informal meetings, and other healthcare settings. However, it took more than 10 years after that for the first program to open, which was the first cohort of doctors of nursing practice graduated from the Kentucky College of Nursing in 2001. And it was actually 3 years later the endorsement came from the American Association of Colleges of Nurses in 2004. Since that time, there's been lots of papers that have addressed and lots of review and surveys and evaluations. And the most recent paper is entitled The New White Paper on the DNP. And this document looks at where we've been, what we're doing now, and where we really need to go with this. So why did the DNP degree emerge? So in the early 2000s, the Institute of the Office of Medicine published a startling report titled To Err is Human. The report cited the number of deaths that resulted from medical errors, which exceeded the number of deaths from motor vehicle crashes, breast cancer, and even AIDS in the year that they collected the data, which was in 1997. This was followed in 2001 with the other document, Crossing the Quality Chasm, on how delivery should be safe and effective. From this report, new skills were identified. This required some assessment on how we educate our health professionals, and in 2003, the document from the Education Committee stated all health professionals should be educated to deliver, and I quote, patient-centered care. And the document went on to state that in order to deliver patient-centered care, we needed competencies and we needed to be more educated as nurses. So the task then circled back to the IOM, who had created the first document, and in 2010 they released their second document, The Future of Nursing Report, which identified that we needed to educate nurses differently and we needed to allow them to practice to their full potential. The report clearly identified that the practice doctorates were essential to make the changes that were so desperately needed to ensure patient safety and best patient outcomes. I'm pretty confident, knowing the demographics of this group now, that most of you know these documents, and some of you know them probably better than I do. But if you don't, I encourage you to read them, to use them in your quest for knowledge and education, and to use them in your references. And so I hope that you have had some chance to read these. It is very important that we know where we've been so we know where we're going. So how do DNPs impact patient outcomes? This is a public service announcement actually out of Florida, so all of our Floridians that are on the call may recognize this if you haven't seen this. I was quite impressed with it as it really depicts what we do as doctors of nursing practice. It is focused on the nurse practitioner as the DNP, but it is applicable to all DNPs.
Hi, I'm Mark Davison. Getting and staying healthy is a journey most Americans are constantly trying to achieve to live longer lives. As a former collegiate athlete and now life coach, I value health and wellness. Therefore, I see my primary care provider yearly for well checkups. However, it is just as important to see a healthcare provider when you're not feeling well. Currently, more than 40 million Americans are uninsured, and many people do not know their options to access their medical care. Throughout the nation, most people can identify when they go to a doctor's office. They may see an osteopath, a nurse practitioner, a physician's assistant, or a medical doctor. But what about when your nurse practitioner is a doctor? Some nurse practitioners have gone on to get a degree as a doctor of nursing practice. So what does it mean when your nurse is a doctor? Let's take a quick look at one of those settings.
Are we ready today? How are you feeling?
The Doctorate of Nursing Practice is the highest degree you can earn in nursing along with the PhD, and you can find Doctors of Nursing Practice in all 50 states. To become a DNP, or Doctorate of Nursing Practice, requires the usual nurse practitioner training and then extended courses that go to a higher level of knowledge that focuses on assisting patients to navigate the increasingly complex healthcare system, understanding and learning to influence healthcare policy, providing leadership to be an advocate for patients and families, understanding the latest and best treatment options based on scientific evidence, learning to use computer technology to improve patient care, and developing an understanding of the role, culture, and ethnicity plays in healthcare and healthcare outcomes. All of these skills are important in order to reach the healthcare goals of our nation and of each of us individually. The American Association of College of Nursing recommends a transition to this Doctorate of Nursing Practice degree as an entry level into the nurse practitioner role, allowing your nurse practitioner to become your doctor.
Understanding what the Doctorate of Nursing Practice degree is requires us as practitioners to educate the reasons as to why this particular degree was developed, and to certainly bring an awareness to our patients, the community, and certainly other healthcare professionals who may not necessarily know our scope of practice, or basically what we do. My interest for this degree came out of a passion for working with patients in a family practice clinical setting. With the economic challenges that the United States has encountered over the past years, when many people had to transition into other fields because of a loss of job, the healthcare industry, on the other hand, has and continues to experience a critical shortage of healthcare providers. As a healthcare provider, we have a responsibility to provide quality care and improve patient outcomes within the population we serve. Therefore, this requires advanced scientific knowledge in an ever-changing yet complex healthcare system in the 21st century.
So the real question is, why now?
Why now? Well, for more than 50 years, nurse practitioners have been practicing high-quality care to patients of all ages and socioeconomic backgrounds. Many studies show the quality of care provided by nurse practitioners and the patient satisfaction that accompanies it. On October 5th, 2010, the Institute of Medicine released the Future of Nursing Report. In this report, a key point was addressed that directly affects the scope of practice for DNPs. Simply, it stated to remove the scope of practice barriers that inhibit nurse practitioners from practicing to the full extent of their education and training. Soon after this, the Florida Federal Trade Commission Office released a document urging legislature to do much the same. So you ask, why now? Well, because healthcare demands a change. The Healthcare Reform Act is calling for a new era led by nurse practitioners. And simply because Americans deserve the best healthcare provider that places them first. DNPs will help to move healthcare forward for a better tomorrow. DNPs are the now.
When choosing a health care provider for you and your family, it is important that you know all of the options available to you. With the shortage of health care providers, who will meet your health care needs? Among options for access to a health care provider will include the Doctorate of Nursing Practice, known as DNP, to help close the gap for Americans.
So this is a great PSA that Florida's used, and it is a couple years old, but it captures several of the points that I've already made about the documents and how we got where we are. And this could be applied to any nursing person that is wanting to advance into the DNP level, whether it's in the clinical track, the leadership track, administrative track, nurse executive track. DNPs will move the agenda forward. So this is another poll question. The DNP is A degree, B role, C neither. So just take a few seconds and please select the answer that you think is correct.
Okay, voting has begun. Okay, we have 81% responded. .86% has responded, so I'm going to close the poll and share the results. So it's 56% degree, 39% role, and 6% neither.
Okay. That's very interesting results, but it's also reflective of the catalyst of why I wanted to talk about the DNP and why we need to clarify some things about it, because there is role confusion. There is confusion, rather, about it. The Doctor of Nursing is actually a degree, and it prepares us for many roles and many different roles. A degree that is very practice-focused. It allows for innovation and creating of a scholarly project that he or she is passionate about. I'm a DNP. I'm also a nurse practitioner. My role has varied with both of those preparations. And my scholarly project was the process of which I obtained that degree. And my scholarly project was on self-efficacy, health, and recovery in homeless male addicts. Now, I still function and volunteer at a free clinic in which I see homeless male addicts as well as lots of other patients that need that care. But my degree prepared me to be a nurse leader and to exercise many different roles. And so what we want to clear up is that the DNP is a degree that prepares you for many roles. And we're going to talk more about that. So the recipe for making of a DNP was created through collaboration from several organizations, including the American Association of College of Nurses, the National Organization of Nurse Practitioner Faculty, and the National Association of Clinical Nurse Specialists. Together, standards for the practice doctorate were created. They are known as the 8 Essentials and were delivered in 2006. Regardless of the specialty or background as a nurse, these steps were deemed necessary for education and for role development. They are the roadmap, and you will hear that in the literature or see that in the literature. And I'm going to warn you, the next slide is very busy because it lists all of the 8 essentials, which we're going to break down. So I'm going to get you just to read them briefly, and you can certainly go back and look at them at another time. But just realize that these are stair steps of the foundation for the DNP. And this allows us to say what we do and do what we say. But how does that transition into practice? is if our practice doctorate is based on the 8 essentials, what does that look like on a day-to-day basis at the bedside, in the office, in the boardroom, and other meetings? So we've already identified through the poll that you so gladly participated in, and thank you, and we don't know who answered what, but we did get some good feedback from that there is degree and role confusion. And a study that was conducted in 2015 identified that this does occur. So very similar to the sample tonight, these were DNP, PhD, and MSN subjects who found out that we were not doing a good job of defining who we are, and that they concluded that embracing, valuing, operationalizing DNP prepared nurses is needed to support what we do and to reduce role ambiguity. Other studies also found that values, perceptions, and even sustainability, and were we going to be functional as a degree, varied. So it was a little bit scary. And I will tell you, there have been colleagues of mine, not at South, but colleagues in other parts of my career that have challenged the DNP. And it's been a very interesting journey. So let's talk about what nurses do value. And I want to bring to you this conceptual model. Even though it's several years old, it is still a very solid conceptual model. And we do value structure, and we value process, and we want to see patient outcomes. This is a way that we can explain and articulate how we teach DNP students, how we develop, how DNPs develop their scholarly project, and then how do we transition that into practice. So for the DNP student who might be in attendance tonight, or those aspiring to be DNP students, the structure is the setting in which you would do your scholarly project. The process is what you will do and how you do it, your scholarly project. And then the patient outcomes is how it will be measured and how it will be reevaluated, and then what do you do with that information. And I wanted to share this model because it is foundational to many of the concepts that we teach not only in South, but most DNP programs are using this structure, and it's one way that a student can develop their scholarly project. And I'm going to be sharing a different conceptual model. It is not in competition with this model, it's to augment this model. But I wanted to show you that there are models out there that we need to consider when we are preparing as DNP students, when we are preparing as DNP faculty, and certainly when we're preparing in practice. So how does the DNP articulate and demonstrate effectively the role or roles the degree has prepared him or her for? So that's our question tonight. And what does that look like on a day-to-day basis? So I have to warn you that this presentation is only going to skim the surface, that it really will not answer the question. This is one of those TBD questions. Anybody want to guess what that is? And I wish I could hear your answers, but I'll just tell you. TBD is to, you know, we are a new nursing degree, and we're still evolving, and we still need to determine what impact we're having at many different levels. So you are part of the TBD, and I'm counting on you as nurses, as nursing students, and others to continue your advancement into the practice doctorate. With that said, I want to introduce you to a model that I have wrapped my head around and developed, which is the REACH model. I have to warn you, there's a little bit of motion in this slide, and I can stop that at any point, like now. And we're going to talk briefly about each essential and what the REACH model correlates with. So the scientific underpinnings of practice is the essential one. It's the first competency that the American Association of Colleges of Nurses and the other organizations put together as critical for DNPs to have in their toolbox. It is the solid foundation in which we build upon. Many sciences, biology, physiology, psychology, contribute to our nursing body of knowledge, but we have our own body of knowledge, and that includes those things plus theories like middle range theories and concepts that guide our day-to-day practice. DNPs must be prepared to conduct, translate, and utilize research in order to impact patient outcomes. And although some DNPs students may generate new research, they may not. They have to have a solid understanding of the process. So the competency here is research, and the role of the DNP, regardless of specialty, will require vast knowledge in research. So we must integrate nursing science with knowledge to reach the highest level of nursing practice. The second competency is systems leadership and quality improvement and systems thinking. It builds upon the first essential, and I'm confident everyone in attendance tonight recognizes and admires a leader who has impacted them personally or professionally. I have had great teachers, both nurses and other health care professionals, who have invested in my journey. They all possess effective communication skills, both delivering and listening, that took me to where I was, to where I needed to be. I think of nurse leaders as coaches. Coaches are accountable for putting together a plan that will work on a court or a field to hopefully win the game. Likewise, nurse leaders are accountable for developing patient safety and quality of care guidelines that will hopefully impact patient outcomes. Now, we're not playing a game with patients. That's not my intent. But we need to help patients win at their health. Paramount to winning is educating and exercising our clinical expertise to impact patient outcomes. So the two initials for this particular essential is educate and clinical expert. Essential 3 is clinical scholarship and analytical methods for evidence-based research. We have to have evidence-based to practice. And the roadmap and the task force that was created prepares us to contribute science by translating research, disseminating, and integrating research. The DNP platform curriculum does a great job of marrying nursing science, knowledge, and skills to nursing practice. So we embrace research in not only in the curriculum, but when we are in practice as well. So research and clinical expert are the two components to this model for the essentials. Oops, I'm going the wrong direction, sorry. The fourth essential is technology, which I'm having trouble with. So I would guess to say tonight that you probably have a minimum of 2 devices on during this presentation. I do. I have my cell phone beside me. I have 2 or 3 computers, and I'm sitting in a smart classroom, so I've got my PowerPoints on both my right and my left. We're inundated with technology. And DNPs are prepared to create, disseminate, utilize many technologies while still weighing the legal and ethical implications of technology. We have to be prepared because our consumers are prepared. The patients also use many forms of technology. So this is so important. But remember, technology is a tool. It's just like a stethoscope. In this case, it is a tool to educate, find information, communicate effectively, and advocate for health literacy. Despite our advances in technology, health literacy in the United States still remains relatively low. DNPs are leading the fight on health literacy. We want our patients to be in the know. We want them to be knowledgeable. We are partners with them, and we communicate that to them. So we need to use our technology effectively. However, I will tell you that there is barriers to technology when we use it to get between us and the patient. And there's nothing more upsetting to me when I make a site visit and I see the student with their head in the computer and the patient on the other side of the room, and they're talking to the patient and they're typing the entire time and they're not looking at the patient. That technology has just then become a barrier to that student's learning and that patient's outcome. And so for those students in the room, I want you to put down your devices. I want you to put away your computer. I don't want you to let that be in between you and your patients, but use technology effectively so that we can transform healthcare. Essential 5, healthcare policy. This is my favorite of all the essentials. And I'm not saying that because I'm an expert. I'm certainly not. But I'm certainly more confident and prepared to weigh policy issues on many different levels that influence delivery systems, address health disparities, and most importantly, tackle access to care issues since completing my DNP program 6 years ago. To do this by serving on local, regional, state, and national boards. They educate local, state, and national representatives on what they do and issues in healthcare that matter to patients. They influence financing, regulation, and delivery of healthcare. They act as advocates for disparities, calling out unethical and unequitable policies. And of course, we lecture in nursing courses and bring healthcare policy to the bedside. It is very important that we educate ourselves on healthcare policy because other people will be making the decisions for us. And this is one area in my DNP program that I felt that I gained tremendous knowledge and embracing it. I've really enjoyed meeting with the legislatures and state senators and other lobbyists and serving on nurse practitioner boards to make change happen, and it's been very effective. So this is advocacy in the best form in a healthcare policy. Essential 6 is interprofessional collaboration for improving patient and population health outcomes. Nurses are great at health promotion and reducing risk. And we know that this was mandated in the Institute of Office of Medicine report. Nurses make up the largest discipline, and we are far great collaborators, or better collaborators, than most of our other shared disciplines. We remain objective, and we use evidence to guide our thinking. However, we often take the back seat in leading collaboration, and our healthcare system is desperate right now, and we need practice models that include peer review and collaboration. So patient outcome hinges on nurses stepping up at all levels, and DNPs are prepared to step up through their knowledge and skills gained in communication, collaboration, and implementation to take us to the next level. It takes confidence, and I might add experience. I call this think like a nurse. So one of the stories that I would like to share after I finished my DNP program, I was practicing in a urgent care facility. Usually I was there with a physician. Sometimes I was there solo. And a patient, a 44-year-old Korean woman who came in with a blood sugar of over 400, positive glucose and negative ketones, presented, and she likely had been diabetic for months, if not years, and she presented with symptoms that was concerning to her family, of which one of them spoke some broken English. The DNP who saw her, I realized that she needed an intervention immediately to get her blood sugar down, and a second intervention to get her on the right track, i.e. to refer her to a primary care physician where she could be followed. She had no insurance. My collaborating physician that day, who I ran this by, who is a dear friend of mine and I have great respect for, wanted to immediately send this uninsured, non-toxic but elevated blood sugar patient to the emergency room so that she could wait for 6 hours or more until she was seen. I paused a minute, gathered all my evidence, and I backed up and I said, Dr. So-and-so, I think I have a better idea. And she said, oh. And so I went on proceeding to share my plan that included calling a pharmacy and collaborating with them to get her insulin. We did not stock insulin in this urgent care facility, which was also a problem. Working with her nephew who spoke English or broken English to understand the importance of getting her blood sugar down, checking her blood sugar. So he went off to the local Walmart, picked up a glucometer that I was able to teach her how to use, and her nephew, give her insulin, keep her in the office, of course start it with a standard insulin dose to get her blood sugar under control, certainly not low, but under control. And then within about 2.5 hours, I was able to discharge that patient, had referred her to another office who could see her in the next couple days, and was able to gather more history and get more labs on her so that when she walked into that office, that everything was done. Now, the physician wanted to send this patient to the hospital, and I said, I don't think she meets criteria, and she will set over in the hospital. They're not going to admit her. She has no ketonuria. Why are you sending her? But that's the differences in how we practice. I think like a nurse. I knew I could educate that patient. I knew I could educate that family, and I knew that I could get that patient stable so that they could avoid high costs and avoid long waits and probably a very dissatisfied situation. So it's very important that we collaborate and we speak up. So this entails both education, advocacy, clinical expertise, and obviously treating the patient holistically. Essential 7 is clinical prevention and population health. And like I said before, nurses are grounded in health promotion and risk reduction. We recognize when somebody needs to change. DNPs are leading this, whether you look at Healthy People 2020, we are prepared to help patients through partnering with them and helping them with their clinical skills and helping them understand their bodies so that they have longevity and a quality of life. And this begins with strong communication skills and education and advocacy. Oops, went too far. And this really entails all of the REACH model. This is very much inclusive of all of those. The last essential advanced practice nursing is broad. And to explain it, DNPs, the DNP is a degree, we've already established that, but there are many roles. Those roles are specialized roles. These have expertise and advanced knowledge and skills in many areas of nursing. As I've said before, I'm an NP, an ER background. I've been teaching suturing classes and other office skills classes for years, and that's one of my expertise. I have colleagues that are DNPs that are in women's health or who are nurse executives. So we share advanced practice in that we have a specialization in what we do. So just to incorporate that in a very holistic model of care, we do that considering all of the patient and the impact that's going to have on the entire patient, and that's why we are masters of patient-centered care. So a day in the life of a DNP can vary from being a nurse practitioner or a nurse executive or a nurse anesthetist or a clinical nurse specialist. But we all can use the REACH model in which to explain what we do and to demonstrate what we do. The DNP is a degree, what we do are roles, and these are roles that we have as doctors of nursing practice. So this is just a little summary of the day of my life as a DNP. This started off as a poster, so this is one of my practice days, so this isn't my nurse educator day. So when I'm in faculty practice on Mondays, I usually start the day very early, and of course I start it with coffee, and I start it with coffee online with DNP students posting, and I might be reading about their passion that's driving their project, their objectives they've written, and I'm also teaching NP students, so I'm online early in the morning before I go into practice. So I'm using my research as well as my educator roles to demonstrate what I do as a DNP. By 7 o'clock, I need to do some self-care. So that's self-advocacy. So I'm out walking at least a mile and taking care of myself before I go into work. I arrive at a clinic. I have an NP student with me that day, or maybe a DNP student. I have 2 DNP students that I'm working with this semester and next semester on Mondays. We lead case discussions. We talk about how we interact with other professionals. Counseling is in my building, so we work very closely with them. I may answer emails to faculty or the deans or physicians that have called me regarding some referrals I've had to patients. So I'm advocating. I'm definitely exercising clinical expertise, and I'm doing this in a very holistic, looking at the entire patient. And for me in student health, I want to know, does this affect their ability to go to class? At 9 o'clock, I start seeing patients. At 12 o'clock, I present an evidence-based wellness initiative to a committee of academics and peer educators who want to establish a wellness program at our college. At 2 o'clock, or 1 to 2 o'clock while I'm eating lunch, I'm reading students' notes. I'm back away from my clinical role. I'm back looking at what's going on with my NP students. And between 2 and 4, again, I start seeing patients. One of them or a couple of them, usually they come in late afternoon, or could be concussions. This is a typical, this is one of my days in which then I start teaching students about concussion care and the tools that we use in our trade for concussion care, and develop the concussion protocols. In late afternoon, I'm reviewing and debriefing the student. Okay, what have you learned? What's been confusing? What essentials have you accomplished? What objectives have you accomplished? At 5 o'clock, I probably am on the phone discussing with either a dean or the athletic trainer or someone about these students and the concussion protocols. And later this evening, I go to a dinner, a legislative dinner, and we hold these a couple times a year, in which we invite our legislators in, and we provide an overview of our practice issues and challenge them to support unrestricted practice, which is our agenda here in Virginia. And as the president of this nurse practitioner group, which also includes nurse practitioners and DNPs, we strategize to increase our membership, discuss practice issues and restrictions. And by 9 o'clock that night, after this meeting's over, I'm back calling students, because I have office hours at 9 o'clock at night, and I'm online, or I'm calling them, and I'm discussing the essentials that applies to their project or some other element of their project, grading papers, often talking to Dr. Horton online, late, or on the phone. And then I say, lights out, Alice. That's from the famous movie Parental Guidance, which is one of my favorites. And that's just sort of a day in a glance. That is definitely not every day. Not all my days are that long. Some of my days are longer. So I'd like to conclude our time together with telling you about a DNP student that I've taught recently, and she looked at this REACH model, gave me some critique, and she said it really covers the complexity of the role, and that she agrees with the nursing profession that we need to develop a cohesive understanding of the practice doctorate, because if we don't understand it, how can others understand it? So there's a couple very quick YouTubes. Actually, I think I'm going to skip this one. I apologize just for the sake of time. And I'm going to go to the next one.
I kind of fell into nursing because I had a really bad accident, and I was taken care of by a really caring nurse, and that's why I chose nursing. I am Tamiko Smith. I am in the Master's of Science Nursing with a focus of family nurse practitioner. I chose South because of its name and actually convenience. I had some people that were already in the program who worked with me, and they highly recommended South. And after communicating with the staff, I was convinced. We were in a program that was considered boot camp because they would come on the weekend and get the instructions that the campus student got in 1 week. For me, the program took about 18 months. My plans are I'm actually enrolled with South once again for the Doctor of Nursing practice. I'm enrolled in the DNP right now. My favorite part of the program was when we interacted with other students in our advanced health assessment class, and I've met a lot of people, and I've interacted with a lot of instructors who were very knowledgeable.
I was really pleased to find that and to share that with you. And the next one is something similar. This is also a South University student talking about South.
South University is very welcoming, from admissions to the people who answer the phone, the professors. Everybody's always willing to help. They're very professional. They know what they're doing. They know what they're talking about, and they really want to help you advance. I was looking at different nursing programs, and there's something about the South University experience. I like the fact that they had an online program. You know, as an adult, you have a lot of responsibilities. I work full-time, I have a child, I have a family, so it was really important that I got a nice comprehensive education, but you get all this flexibility. I've always had nursing in my life. My mom's a nurse, so I saw that growing up. I've been a nurse for quite some time, and then I just wanted to be able to do more, a little more independently. So as a nurse practitioner, you are still part of the care profession, and you could definitely give people more. You can diagnose, you can treat, you can prescribe, and eventually I'd like to get a doctorate degree. My name is Fanny, and I'm getting my degree in Master of Science in Nursing with a specialization in Family Nurse Practitioner.
So although she was an NP student, maybe some of you know her, I think her message is then, I'd like to get that doctorate of nursing practice. Forward thinking, the ability to know where she wants to go in nursing. So according to Moran and several of the authors of the book that we use actually in our program, the ultimate impact of the DNP graduate on nursing as a profession, healthcare, and society will be the rest of the story. Remember the TBD? The to be determined. So what will be your story? So what are your next steps? And we don't have a poll question for this. I wish we could have included that. But I want to tell you what my next steps are. My next steps are to develop a research study around this REACH model, not only, and be three-pronged, not only for DNP faculty to give feedback on, but DNP students that are currently enrolled, as well as DNPs that are in current practice. So I want you to think about what your next steps are. Will your journey include continuing your education and being a researcher, an educator, an advocate, a clinician, and treating the patient holistically? And the last thing, I won't read this, but I certainly share this with you. When I graduated from my DNP program 6 years ago, it was also during the time that my daughter was having our first grandchild. And he actually arrived 3.5 weeks early on the day that my scholarly project was due. So I had to tell you, this isn't going to happen. I wasn't anticipating this. And what obvious to me, experiencing that with my daughter and experiencing the DNP, was there was a lot of parallels in my emotions and what I was thinking. So I wrote this poem and I gave it to my faculty and my cohort, my faculty and my cohorts as a gift to them, and we were able to really, relate to it as DNPs in the birth, because we weren't the first program, we were in the first class of the ODU DNP program. So I appreciate those that have gone after me, and I also appreciate those that have gone before me. I want to close with just hoping that you have found some reason to be curious, reason to continue, reason to be interested in continuing your education as a doctor of nursing practice, so that you can impact patients at all levels. And I hope that you will talk about it and share it with other people. I want to provide some contact information, not only mine, but Dr. Lee Horton, who's the director of our DNP South University online program. And any of your academic counselors can also provide you with information. And even if you're not quite ready for the DNP program and you just want to talk about your journey in nursing, I am more than happy to dialogue with you. There is a disclaimer that South University requires, so that is included in the slideshow. And then my references are at the end. Kim, that's all I have for tonight. Unless someone has some questions in the chat box, I think we've gone over just a few minutes, and I just want to thank everybody for their patience and time tonight, and I've really enjoyed being with you.
Thank you so much, Dr. Taylor, for that very informative and action-packed presentation. We appreciate it. Does anybody have any questions? If so, please type them in the question box on the side. While we're waiting for questions to show up, I do want to just let everybody know you should see a survey at the end of the presentation. Please complete it. It really helps us guide our programming and develop our programming for your purposes. And if you're not able to complete that one, there will be a survey that will come in the email to you with a copy of the recording of this presentation. So again, I appreciate Dr. Taylor's time. Do we have any questions? We're getting some, thank you, great presentations.
Oh, well, thank you. Well, I have to digest things from time to time, so if anybody has questions, please feel free to use that contact and email me. And again, I'm confident Dr. Horton will also be available, and other people at the graduate level, as well as the academic counselors. Thanks so much, Kim.
You're welcome, and on behalf of all of our attendees, I say thank you so much for taking the time to present this information for us this evening. And thanks to all of our attendees. It's been great spending this time with you this evening. Everybody have a great evening.